Good morning, everyone. It's good to be with you this morning. As was mentioned by the secretary, my name is Malcolm Augustine, Maryland State Senator from Prince George's County. I am also a board member on the Maryland Patient Safety Center. And so I'm very pleased to be here with you today and to introduce our speaker. Our speaker is Kesha Baptiste-Roberts, that's Dr. Kesha Baptiste-Roberts, who is the chair of the Department of Public and Allied Health and an associate professor at Morgan State University. There's no chairs for Morgan State. I would expect something. I usually don't come into rooms and not hear some chairs on, when we call out schools. She holds a Bachelor of Science degree in biology from Juanita College, a master's in public health degree from St. Louis University, and she completed a maternal and child health certificate in addition to her PhD and postdoctoral training in epidemiology at Johns Hopkins University Bloomberg School of Public Health. Another local school, no Hopkins people? All right. Dr. Baptiste-Roberts is an accomplished researcher, having authored or co-authored over 30 scientific publications, including journal articles and book chapters. She is the co-editor of a book entitled Obesity in Pregnancy. Dr. Baptiste-Roberts has published research in maternal and child health, women's health, type 2 diabetes, obesity, and racial ethnic health disparities. Her early work was primarily focused on pregnancy-related factors and their influence on cardiometabolic outcomes for both mother and offspring along the life course. That is a mouthful. I hope I did okay with that. During her career, she worked on health among sexual minority women and substance abuse. Most recently, she has been working on improving maternal health for underserved communities utilizing telehealth and doula services. She is currently the principal investigator of an ERISA-funded maternal child health research center. She was HRSA, sorry. I get my acronyms mixed up. HRSA, sorry. She was the 2021 recipient of the Abraham Lilienfeld Award from the Epidemiology section of the American Public Health Association, which recognizes excellence in teaching epidemiology over the course of a career. This award is given in memory of Dr. Abraham Lilienfeld, an outstanding teacher, scholar, and former chair of the epidemiology department at Johns Hopkins School of Public Health. She has held leadership roles in several national organizations, including the American Public Health Association, where she served as a governing counselor and section counselor for 2 terms. She has been the co-chair of the Scientific Program Committee for the past 7 years. She is a past president of the Society of the Analysis of African American Public Health Issues. She has also served as an executive committee member on the Sankofa Collaborative, a collaborative of public health leaders focused on providing a forum to promote the health of minority women affected by HIV through research, policy, advocacy, and social justice. So, folks who are here today, let's give a big round of applause for our guest speaker, Dr. Kesha Baptiste-Roberts.
Good morning, everyone, and thank you. Wow, that was robust. And thank you so much for such a generous introduction. I will say it's very interesting to sit down and hear someone introduce you and list all the things that you've done. You don't really get a chance to reflect on that. And I was thinking, who is this person and when did they have time to do all of that? So today I'm just gonna talk about, can I have my slides up, please? Rethinking our approach to maternal mortality. And some of the things I'm going to talk about, Dr. Scott already talked about. There we go. Okay. So we've all been seeing these headlines. Maternity's most dangerous time after new mothers come home. How many dead moms will it take to stop America's maternal mortality epidemic? And these headlines have been scary, and we've been seeing these for the past couple of years. We've also been seeing reports of women feeling mistreated in maternity during maternity care, articles describing racism and sexism as underlying contributors. In addition to these headlines, You may have seen the documentary Aftershock, which documents two families who suffered maternal loss, two grieving partners joining together and becoming activists, seeking justice through legislation, medical accountability, community art. You may have heard or seen Charles Johnson. He was recently at the second annual Leaders in Black Maternal Health Award Luncheon here in Baltimore, hosted by the Baltimore Healthy Start and the Reginald F. Lewis Museum. And he's been working on helping to pass legislation, including the Preventing Maternal Death Act of 2018, the Protecting Moms Who Served Act of 2021. And we also want to remember Amber Rose and Bruce McIntyre and Shalon Irving. And she's kind of special to us because she's an alum of my alma mater, Johns Hopkins, Bloomberg School of Public Health. And she was also a former postdoctoral fellow at the Kellogg Community Health Scholars Program at Morgan State. So we're going to look at some of the things that are driving these stories. So I want to describe the trends in maternal mortality, summarize briefly some of the interventions aimed at reducing maternal mortality, and then explore some novel, holistic approaches. So just some definitions. So we know that maternal death is death of a woman within 42 days of termination of pregnancy. And then we have pregnancy-associated death, that's death of a woman while pregnant or within 1 year, 365 days, or pregnancy conclusion. And then we have pregnancy-related death, which is the death of a woman while pregnant within 1 year of pregnancy, irrespective of the duration and site from any causes related to the pregnancy. So here's a chart of maternal mortality ratios for selected developed countries. And we see the outline, the orange to the right of the screen. That's the US. So the mortality ratio in the US is about 2 times that of Canada, 3 times that of the UK. Of course, there are lots of factors that are contributing to this. However, in every other industrialized country, maternal mortality is decreasing while it's increasing in the US. If we look at what's happened between 1990 and 2000, we've had some success, right? With the onset of, initiation of prenatal care, antibiotics, blood transfusions, we've made some successes and then we sort of leveled off. So let's see what's happening now. So in 2021, about 1,200 women died of maternal causes in the United States compared to 861 in 2020 and 754 in 2019. So we see in the graph that the rates are increasing. And so the number of maternal deaths increased by 40% from 2020 to 21. And how does Maryland compare? So the rates for Maryland are in orange. So 2009 to 2013, the rates for Maryland are higher than the US. And then 2014, we're lower than the US and we decreased, so that's great. And then 2018 to 2021, we're still lower than the US rates, but we're starting to creep up there. So this graph here shows maternal mortality rates by race and Hispanic origin. So on the y-axis, we have the deaths per 100,000. On the x-axis, we have race ethnic groups. And the different colors depict the mortality rates for years 2018 through 2021. So if we look at the first set of bars, this is for all race ethnic groups, and we see a steady increase in maternal mortality with a bit of a spike in 2021. So there's a 38% increase from 2020 to 2021. We see a similar trend for non-Hispanic Blacks as well, an 18% increase from 2018 to 2019, a 26%, thank you, increase from 2019 to 2020, sorry about that, and a 26% increase from 2020 to 2021. So although we see an increase among non-Hispanic white women, the magnitude of the increase from year to year is smaller. So 20% increase from 2018 to 2019, 7% increase from 2019 to 2020, and a 39% increase from 2020 to 2021. And among Hispanic women, the percent increase from 2020 to 21 was 53%. So this is just another graph showing maternal mortality rates by race, Hispanic origin again, and the yellow line on the top, that's non-Hispanic Black women, and the green line is non-Hispanic white women. And we see a widening gap between these two groups. Hispanic mortality rates are also on the rise, and we see that the rates in Hispanics is slightly higher than that of non-Hispanic whites in 2021. So we need to start taking a look at this group as well. And here now, let's look to see what's going on in Maryland. So we see a similar trend with non-Hispanic whites, that's the red line, having the lowest mortality rates. And then there's a steady decline. Among non-Hispanic Blacks in the green, there's also an overall decrease. So of course, in this graph, we have data for we don't have data for 2020 and 2021, not on this one. We will see it on the next slide. So here we see the maternal mortality ratios again for race ethnic groups, and we see an increase for all of the groups, but a 50% increase among non-Hispanic Blacks, an 80% increase among non-Hispanic whites, and a 38% increase among Hispanics. So this disparity persists between non-Hispanic Blacks and non-Hispanic whites. And here we'll look at the trends of pregnancy-related deaths. Here, and on average, we see a steady increase. So here in Maryland, we've been hovering around 53%, except for this spike that we see in 2017. For pregnancy-related mortality, there was a slow, steady decrease until 2017. Where there has been a shift and a resulting increase. So if we look at pregnancy-related mortality ratio, highest rates among non-Hispanic, Native Hawaiian, or other Pacific Islanders, and the second highest is non-Hispanic Black, and the lowest is Hispanics. So now let's look at the rate of non-pregnancy and pregnancy-related deaths in 2010 through 2018. So the pink bars, I hope they look pink, or maybe salmon, are non-Hispanic Black, and the red bars are non-Hispanic white. And we can see the rate is significantly higher among non-Hispanic Blacks for pregnancy-related mortality. And although the rate of non-pregnancy-related mortality among non-Hispanic Black is lower than that of non-Hispanic white, this is not statistically significant, the difference isn't. So now let's think about the causes of these pregnancy-related deaths. And so when we look at this graph, we see that the number one, the leading cause is other cardiovascular conditions, and second is infection and sepsis, and third is cardiomyopathy, and this is for the US. And here are the leading underlying causes of pregnancy-related deaths. Data, and this data is from the Maternal Mortality Review Committee, and this is in 36 states. This is 2017 through 2019. And these maternal mortality review committees, as Shelley talked about, are multidisciplinary committees that convene at the state or local level to comprehensively review maternal mortality cases. And here we see that the number one underlying cause is mental health conditions, followed by hemorrhage, and then cardiac and coronary conditions. And when we look at pregnancy-related deaths, here, I think I repeated this slide actually. Okay, and then the most frequent underlying causes of pregnancy-related deaths among non-Hispanic Black women, again, mental health conditions, number one. Having a little technical issue here. Okay, here we go. Right. Sorry, I lost my place. So the most frequent underlying causes of pregnancy-related deaths among non-Hispanic Black women, we have the cardiac coronary conditions, cardiomyopathy, and then embolism, thrombotic issues as the three most frequent pregnancy-related deaths. And then among Hispanic persons, again, the number one cause is mental health, followed by hemorrhage, and then cardiac coronary conditions. And then for non-Hispanic white persons, mental health, hemorrhage, cardiac coronary conditions. So you see for the different racial groups, the major underlying causes are different. And that was the point of these slides. The key point here, or the key take-home message, is that 84% of pregnancy-related deaths using this maternal mortality review committee preventability determination were determined to be preventable. And that's exciting because that means we can do something about this. So when we look at Maryland, using the data from the Maryland Maternal Mortality Review, their 2020 annual report, the number one underlying cause, non-cardiovascular conditions, non-cardiovascular conditions, cardiovascular conditions, and then the third is suicide. So that's very different, a little bit different from what we see on the national level. And again here, around 80-something% of these deaths are preventable. So that really gives me hope that we can do something about this. And from the, again, the Maryland Maternal Mortality Review, the leading underlying cause of non-pregnancy related deaths, again, start with substance use with an unintentional overdose, non-cardiovascular medical conditions, and then cardiovascular conditions. And again, 85% of these non-pregnancy related deaths preventable. So if we look at this slide here, this shows the timing of US maternal and pregnancy related deaths. And we see here that over 52% of these deaths occur days 1 through a year. So that means that this postpartum period is really important. And if we look at more recent data, again, it tells the same story, right? So over 53% of the deaths are occurring 7 days up to a year. 48% are occurring between 0 and 42 days. And in Maryland, 44% are occurring between 0 to 42 days. So what are the key points here? Some of the take homes I got from looking at this data is behavioral and mental health is crucial. Crucial. Second, this postpartum period, we need serious intervention and support at this particular time. In our culture here in the US, you have your baby, everyone's happy, people take pictures, and then you go home. And then you have to figure it out yourself, or you and your partner have to figure it out yourself. And it's a time of transition. It's a time that I don't think people really talk about honestly about what's going on. And so women really walk into this time just not knowing what to expect and being very uncomfortable. And the men too, because mom is going through a transition, dad is also going through a transition, and this union is going through a transition with the addition of this new person. And third, these race ethnic differences. And I know my colleagues will talk more in depth about that later on. These things are persisting. As Dr. Brown is in the room, and when she speaks, she says, I've been doing this for 100 years. And why are these things still persisting? So this is just, again, different slide. So here are some things, and Dr. Scott mentioned these earlier. Here are some of the things that we are doing here in Maryland. And I'm so excited that we are one of those states that are that are we're making it happen. We're doing things. So our Medicaid extension, so coverage for women up to 1 year postpartum, which addresses this postpartum period issue. Medicaid expansion, allowing birthing people greater access to preventive care during pregnancy. Paid family leave. Doula reimbursement policy, and I'll talk a little bit more about doulas later on. The Maternal Mortality Review Committee, this is key. And this is something that is evolving as we're growing and learning. The Fetal and Infant Mortality Review Team, and then the Perinatal Quality Collaborative. So these are some exciting things that are going, and we're very responsive. So some recommendations or some thoughts regarding behavioral and mental health services for pregnant and postpartum women. And so I started with screening. Yes, we need more screening. Wonderful. We need to increase screening, but we need to increase provider awareness of substance abuse, other mental health conditions. We need to expand services. This is great. And then I paused here because we can't expand services if we don't have a workforce that's trained. And so I said, well, I don't want to say we expand services. We have to address this workforce issue, the lack of diversity in the workforce that provide mental health services. That's number one, and we just don't have enough. And we know that mental health needs are increasing. It seems like exponentially. I don't know if I'm just being dramatic, but I have a teenager. It just seems as though mental health needs are increasing dramatically. And I think as a mom, I've become a therapist myself, having to deal with the emotional needs of a teenage girl. We need to continue to work on reducing the stigma around mental health. I know that some of our celebrity figures have been working on this, talking about mental health, and trying to reduce the stigma. We really need to do that. And we need community-based support. So people don't live in clinics. They don't access clinics every day. And so they go back to their communities, and this is where they live. And we want them to thrive there. So we need to resource community organizations so that they can support their communities and their women. And so how do we do this? Resources, 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 yes. But we need to have true equitable partnerships. We need to make sure that our communities build capacity. And this is where partnerships come in with academic institutions. But I'm saying partnerships over and over because it has to be a partnership. It can't be where we come in, we get this grant, we come in, we do this research, we take from you, and we're like, okay, great, I got my publications, I'm on my way to associate professor, and then we leave you behind. Community they don't want to work like that at all. So we need to partner with them. They are the experts in their lived experience. And then postpartum care. So yes, I'm excited about the expansion of doula services. I'm excited that this is a strategy. However, we need systems and processes in place that are not prohibitive for doulas to do the work that they do. So yes, we need certification. Yes, we need a process, but we need to make sure that these things are accessible to the people who are already in the field doing the work and supporting women in their community. So we also need to increase awareness about doula services. A lot of people don't know about it. We also need to incorporate telehealth services as well. And again, community-based resources for safe spaces. In almost every slide that comes next is community. I have community in there. And of course, in expanding access to doulas, we need to make sure that doulas can live and do this work and take care of their families. So when we look at Medicaid reimbursement, we want to make sure that people can actually be a doula as a profession. In thinking about doulas as well, we also need to work on the culture in where people give birth, right? So doulas need to be included as part of the birthing team. And when I say included, not just sort of pushed to the side, but they need to be recognized and respected for the role that they play in this birthing team. And so there must be mutual respect between the physician, nurse practitioner, the nurses on the floor, and their role and their work must be valued, and there must be mutual respect. So there needs to be some training. And I know that there are doula groups that are getting together, that are advocating, that actually have seats at tables where their voices are being heard, and that's super exciting. Next is this issue of these race ethnic disparities that are persisting. We've made progress. We can now say racism, the word racism, in forums like this, so we've made progress. But we need to address unconscious bias and structural bias in healthcare systems. We need to do that. We need to focus on providing quality care for all birthing people. And we need to train healthcare providers and professionals and office staff. So when people come in the door, we need to have training that centers on equity. And again, we need to bolster our community organizations as well. So I know that this will be discussed later on. And then our community-based organizations, I can't say this enough, they are critical partners. This is where our women are. This is where they work, live, play, socialize. And so we need to include these organizations in everything that we do. They need to be involved in mobilizing and advocating and providing voice to the lived experience of the people in the community. So I think that the future is bright, and I will tell you why. So first of all, HRSA has invested more than $8.7 million to address maternal mortality and improve maternal health in the state of Maryland. And this was from a press release back in September. And so maternal health research, we received $2,884,000 to establish a new research network that will support minorities serving institutions of higher learning in studying disparities in maternal health outcomes and identifying effective methods and strategies for addressing these things. So this is key. Our minority serving institutions have been largely left out of opportunities to conduct maternal health research, to train maternal health scholars, and really add in diversifying the MCH workforce. And through organization, advocacy, this funding came to be. And so we are very excited at Morgan to have the coordinating center that's going to be responsible for working with the 16 research centers across the country, and that coordinating center is led by Dr. Bronner. And then we also have the research center that I will be leading at Morgan State University as well. Second, we have more HRSA funding coming to the state of Maryland to support parents and communities with the highest rates of maternal death. So over $2 million for Healthy Start initiatives. And then more money to increase access to integrated maternal health services. Additional funding to expand access to maternal health care, $1.5 million to establish maternal health task forces with a focus on innovation, implementing strategies to improve maternal health service delivery. And then some additional funding to build birthing facilities capacity to reduce maternal death and severe illness, in addition to funding for support for mothers and their families with Medicaid eligibility redeterminations. So I talked a little bit about doulas, and there's a lot of movement and momentum around doulas right now. The landscape is changing rapidly. Different states are doing different things, and doulas are organizing. And so Dr. Jeffers over at Hopkins, she just brought together a group of doulas, policy experts, healthcare providers, payers, patient advocates, to figure out how do we integrate doulas into the system effectively. So I'm really excited about that. And then I think what I'm most excited about is the future, is our young people. So I'm going to tell you a little bit about this program that was that took place on our campus. And this is called Nourish. It's new opportunity to uncover resources, intuition, spirit, and healing. And so this program was developed by a team from the Black Women's Health Imperative led by Dr. Kanika Harris. And this was a pilot program, and they selected Morgan State University to do this pilot. And so they took a unique approach to this doula training program. They focused on knowing by doing. And so the students were involved in actively doing things. They also focused on supporting the community through decolonizing information and then also expanding the legacy of the Black midwife. So there were 40 students that were recruited to participate in this program. They graduated 38 students. And the reason why I'm so excited about this, because when Dr. Harris approached me, I said, I don't know that we can really engage undergrads for this long of a time. But I was there on the weekends, sometimes all weekend, Saturday and Sunday, and they were excited, engaged. They had so many questions about caring for their bodies, about their bodies. It was just incredible. And so this is the Nourish team, led by Dr. Kanika Harris. And I just wanted to read some of the testimonials from the students just to show them here. I will be able to take the information that I learned and save it for myself when I have children, as well as pass it along to others that I know who are expecting. And another student said, it truly felt like a sisterhood was being created. It reminded me of how nurturing Black women truly are. I felt protected and at peace in the space. So Michael Liu said in one of his talks that we need to increase the health and well-being of women and girls across the life course. We can't try to fix everything 9 months during the prenatal period or even postpartum period. And so I feel like the Nourish program is doing two things. So it's providing a group of doulas from an underrepresented group to the doula workforce. So diversifying the doula workforce, expanding the doula workforce. And these students are passionate about maternal mortality. They've seen the news headlines, and there is fear. There is fear and there is mistrust. And so this program, of course, is work to dispel some of that fear, right? And then they're going to be working with women in the community. The great thing is that these students are now in the process of being certified, and they will be certified to serve women in the community and receive Medicaid reimbursement. So this program is addressing an immediate need. That's number one. Number two, this program is also addressing the health of women of reproductive age who are not yet ready to have children. And so some of the things they learned in this program about self-care, stress reduction, listening to your body, being in tune with your body, they're going to carry this through. And hopefully these young ladies will enter into pregnancy healthier. So with this program, we have sort of a short-term outcome, and we also have the potential to see a long-term outcome. The other thing with young people is that they spread information, and the rate at which they do this is amazing. And so I've seen so many of their Instagram posts and conversations that they're having with other people across the country about what they learned and what they're doing. And some of our students don't necessarily live in Maryland. Well, they're not from Maryland, so some of them have graduated and are now going back to their home state. And so I think we're sitting on a gold mine here. And so the hope is that this program can be expanded across HBCU campuses, and not just limited to HBCUs or minority servicing, but all campuses, so that we can empower our young people. We can have a cadre of women that are there to support other women, and they can be doulas and be reimbursed, serve their community, and also make a living while they pursue their profession. So I am very hopeful, especially because of these young people. So thank you so much for giving me the opportunity to talk with you today, and I will take any questions. Okay. Oh, Dr. Bronner. Dr. Bronner always has a question.
Oh, microphone. Okay. My name's Yvonne Bronner from Morgan State University, and I am so pleased by this wonderful presentation. As you know, as you noted in your data, unfortunately, our rates are continuing to rise. And you have noted some things that our NGOs are not, our community organizations and so on can do. What was not noted as much is the fatherhood role. And we know that our fathers are very important in this. So how would you, what do you think could be done in terms of our increasing fatherhood support for decreasing these numbers?
So I actually think we need to have doulas for dads. I think that we don't appreciate or recognize what men go through with this transition because they don't talk about it like women do, right? And they don't talk about it amongst their friends either because I don't think men interact that way. So they don't really have a space. It's not cool to talk about those things. So I do think, and I don't know how that would work, but I do think if we had a similar model for dads, that would be very helpful because then they could understand what's going on with mom. And so they can show up the way that mom needs them to show up in order for mom to do what she needs to do. And they also don't feel neglected. So that's one of the things that I think would work. Before, I guess, something that can be done, there are parenting groups that exist. I don't know how much men really participate in those things. But I think that we need to make it cool for men to have conversations and be vulnerable about issues around this issue. And I will say, so Charles Johnson, Bruce McIntyre, these people that are out there advocating and being vulnerable and talking about their pain and how they're coping is helpful.
Well, first, thank you so much for your presentation, for issuing calls to action and highlighting things that we can all do. The Nourish program's amazing. Did the students get credit or did they get like a stipend to attend? Or did they just do this out of their own desire to want to learn more and engage?
So I do believe that they got a little stipend, but it really wasn't the stipend that drove their participation. Honestly, these students, and I'm telling you, I was shocked. They were very interested and engaged. To see young people getting up and being present at 9 in the morning on a Saturday and Sunday, it was incredible. They had so many questions. And I was wondering, what is going on in health class in high school? Don't they cover these things? I was shocked at some of the questions they were asking. And I think one of the reason why I think this was so special was the cast of the team. And so there was a young OBGYN who came in and she was very relatable to the students. And they obviously felt very comfortable asking her questions. And so I think the team was unique. I think there was a relatability and the team met the students where they were. So they really felt comfortable and they were doing things. They had all these models, they were helping, working on each other. And the other thing that happened, and I think that was special, was that one of the young ladies became pregnant. And so they all got to practice what they learned with this young lady. And so they took turns actually helping her postpartum, doing the things that doulas do, showing up, having conversation, helping her with meals or cleaning or just sitting with her. So they got to practice with one of their peers. And I will say during the program, Dr. Harris and her team emphasized, like, this is your community. After you leave here, when you become a mom, you call on someone and they will come. And so they sort of made that commitment to each other.
Thank you.
Dr. Baptiste-Roberts, I'm also really excited about the Nourish program and wanted to know what kind of connections the Nourish graduates have into other parts of, say, the maternal health system, because there's so many connections, that would be ripe in this room right now. And I'm just wondering about some that already exist and some that you might have aspirations for.
So Dr. Harris has been working with the students, connecting them with partners so that they can get their hours and things like that. But her funding ends in June. And so we are hopeful that this can be continued with some additional funding. Yes.
We have a question virtually. How long does it take to complete the Nourish program?
So I believe it was an entire year.
Good morning. I was wondering if I could pick your brain as an epidemiologist for a moment. The recent publishing in the Washington Post about the Canadian study that says Black maternal health is overreported. I know I've spoken to my epidemiologist just to be prepared to have, conversation when people ask about that. And she was clear about how we, go back through and clean the data. And so our numbers, we're not overreported. We still see the disparity, but can you provide guidance on maybe some talking points when that comes up about the inadequate, or not inadequate, but inappropriate focus on Black birthing persons when we talk about maternal health?
Well, I would say this. I trust the folks who do this work at the national level. I don't do the work personally. I don't do that kind of work myself, but I trust what they do. And the thing is, the disparity is huge. And so we know in all data there's error, but that's a huge disparity. And so I don't think that's due to error. That's the simplest way to answer the question. Yes. Hi.
Okay, you can hear me now.
I
Okay,
can hear you.
so start again. So good morning, Kesha. I wanted to echo the sentiments. It's a great presentation, really inclusive. And this is, again, a multifaceted problem, as you nicely elucidated in your talk. And one of the things that's really always really boggled my mind is that when we think about the disparities in healthcare between our Black and brown moms and our non-Hispanic white moms, even when we compare and we can control for education attainment, economic attainment, zip codes of where we live, resource attainment, Black and brown women still do worse. And so can you offer some thoughts about how do we address that issue? How do we narrow that gap there?
So I think that definitely this narrative that when you take off education, socioeconomic status, there's still this disparity. We need to amplify that because so many times people equate Black and brown to low SES, low education, and it's not synonyms for the two things, right? And so there's something else. And so the thing is racism, structural racism, systemic racism. That's what it is. It's weathering. As a woman of color, there's so many things that you have to think about when you walk into a space. There's so many additional questions that you have to answer depending on the space. Those things are stressful. And so the stress is, the disparity in the stress, I think, is huge. So we need to not only name racism, but we need to start doing something about it. And that's the difficult part. And the thing is, I don't think this is new, like we knew this all along, but now we can finally say it. And now we need to do something about it. I think Dr. Jones, Kamara Jones, a couple years ago, she was able to say it at APHA. And now we're done with saying it. Now we need to do something about it.
Is any funding going into language services?
I do not have an answer to that question.
Not enough.
So Dr. Scott says not enough.
I do my patients for out front because the MAs would be yelling, thinking if they spoke louder, they would understand English better. And we know that doesn't work. We're looking at our own portfolio, and I can tell you at the health department, we're not spending enough money on language services. And the language line is not always the best way to provide services real time. So we're taking a hard look at what we're not doing in that space, but at least from the state's perspective, not enough.
And will the Nourish graduates have access to work with moms at the bedside while being in the hospital and in labor?
Yes, yes. It's a full spectrum doula training program certified.
Are the programs to help doulas to establish a new business to help with Black and Brown women?
Repeat the question.
Are the programs to help doulas to establish a new business to help with Black and Brown women?
Oh, so are there programs? Yes, there are programs that are available. So I believe Mom Cares has some training around that as well. So like I said, the doulas are getting organized on a national level.
Okay.
And the good thing is they have a blueprint to follow with the community health workers, right? So I'm very excited about the expansion of doula services. But I also wanted to say, for Dr. Bronner's work with the MSI Research Collaborative, the goal for those research centers is to engage in community-informed, community-engaged work. So we don't want to do what's been done. We really want to do things that are going to be impactful and that are going to address current problems and challenges in communities. So we're not just doing research for research's sake. We really want to solve problems. And so Dr. Brown is advocating, that some of the metrics may not be suitable for the kind of work that we do.
So my question is, this is an intersectional issue, as you said in multiple ways during your presentation. And I'm noticing like most of the people in the room today are women. Most of the people who are caring for women now are women. And how can we address that issue? Because at the end of the day, when we're looking at all of this, we're doing this to ourselves. We're doing this to our daughters and our children. And that's what's concerning to me when I look at the rising maternal mortality rates and this mental health issue is like, how can we see these issues in a way that sort of also addresses the patriarchal systems and the white supremacist systems that we're working in?
Right. So that's a very good question. And I think that we need to sort of, as women, diversify what we do, right? So Dr. Scott is the Secretary of Health. We have more women in Congress. We really do need to start participating differently in the political process. I know that women, we suffer from imposter syndrome a lot. I did this morning. But we have something to say, and we need to get ourselves at the tables. And I tell my students that all the time. Like, you are passionate about something, but there's nothing that's going to happen if you're sitting in a corner just making noise. Like, you need to prepare yourself, do the work, and not only get into the room and get a seat at the table, but you also have to be effective when you get to that table. And if you're not, then you need to go to get your own room and get your own table, and then you invite people to your table. And then they're going to have to eat what you're serving. So I think that we need to be bold and brave and courageous as women and step into places that are uncomfortable And this is where we use our sisterhood. And you call your friend and say, I'm scared. And I did that too. I called my friend who does this and I said, I am terrified. And she said, you'll be fine. And so we need each other. We need to support each other in order to do this work. But we need to be there. Like, we cannot be absent. We have to be there.
Any thoughts to having BH providers doing house calls? So many barriers to get to BH services.
So Dr. Scott probably has a better answer for that question.
We just don't have the workforce in the behavioral health space. Unfortunately, we just don't have the workforce in the behavioral health space. You know, I'm not sure where everyone went during COVID, but Maryland has not rebounded like other states have, with people that were clinicians providing services, returning to those services post-COVID. And so we have a lot of work to do to build back that workforce. Even speaking to the dean at the University of Maryland School of Social Work, she said enrollment is down. And is it down because people are not interested? Is it down because we don't pay them enough? Is it down because it's too expensive? We need to figure out some of those issues to build back the clinical workforce that we need. We are using mental health services, and that's certainly a role, but even through those services, there's just not enough workforce to necessarily provide the services in the home. To the point that you mentioned about our providers, we also need to do a better job at educating our providers on how to ask the questions. It's not, you're not depressed, right? No, I'm not depressed, right? So we need to do a better job asking the questions, but then we need to give the providers the tools once they ask the question, where to refer clients to. And so we have a lot of work to do.
Thank you, Dr. Scott.
Dr. Baptiste, I know, yeah, we have some more time, so don't look at your watch. I think you also alluded to the fact that pregnancy is too short a time to change a lot of what we need to change. And you spoke a bit about the preconception period. Could you expand on that?
The preconception period? Well, that's an interesting, it's hard to sort of pin down what the preconception period is, since most of the pregnancies, 60-something% are unplanned. So I really do think the focus should be women of reproductive age, starting in high school. And I know the return on investment will not be immediate, but I think consistent and over time, we will see some improvement. But I think that I remember from my own self going to my internal medicine doc and said, okay, well, now I'm ready to try getting pregnant. I'm here for my preconception visit. And he looked at me like, why are you here? Just take some prenatal vitamins. And I was shocked because at that time I was doing my MCH certificate at Hopkins doing my doctoral work. And I was thinking, oh my gosh, this is not right. How could he not know about preconception care? But that was my experience. And so I think maybe that a lot of people don't go for preconception care. They don't call it that. Maybe that's not discussed. Again, we're living in a time where the medical appointment is so rushed. Physicians are grappling with RVR requirements and how many patients are you seeing and scheduling and having your surgery block, full. So there are lots of competing things going on. And so it's challenging. We need to change culture. We need to do training. And I really do think we need to focus on women of reproductive age, high school, or maybe even middle school.
Hi, thank you again. My question is around the doula program, and I think it's a fantastic thing and highlighted that it's a safe space for women. My question is, are the doulas that are linked to the Medicaid program mandated reporters?
I do not know the answer to that question. Is there someone in the room who can answer that question if doulas are reporters.
Doulas are not mandated reporters.
Within Medicaid, it's written. No, I'm talking about when they get reimbursed through the Medicaid program. Will they be expected to be mandated reporters?
I don't have the answer to that question. We can get back to you. I don't have the answer to that question. We can find someone in the room later and we can probably get you an answer. Okay, well, thank you so much. And thank you for the discussion.